right, so this is the recap of high blood pressure. There's some things that I didn't talk about. This is just some facts and stats to understand how important blood pressure is. It's over $46 billion annually. It increases your risk of heart attack, stroke, heart failure, and chronic kidney disease and organs, right? Target organ damage. People of African descent develop high blood pressure more often and at a younger age. And only about half of the individuals with high blood pressure have it under control because it's the silent killer. They don't know they have it. Tips on taking blood pressure. Please know these tips. I cannot stress enough how important it is. So if you need to look at the PDF, look at the PDF, read this slide, whatever. Please know how to do it. So the end result of uncontrolled blood pressure: stroke, heart failure, sexual dysfunction, vision loss, heart attack, kidney disease, and failure. Very important. Types of blood pressure. We have essential and we have secondary. Essential blood pressure or primary blood pressure, high blood pressure, essential hypertension and primary hypertension. That's 95% of the population. Then you have secondary hypertension, which is about 5%, and it has an identifiable cause such as medicine, coarctation of the aorta, etc. Then we also have white coat and mast hypertension. These are really like subtypes. Just really need to know what they mean. So white coat hypertension is when your blood pressure is normal outside the office, but it's elevated inside the office. And then mast hypertension is when it's elevated outside the office, but normal inside the office. So they will put these individuals on a 3-month trial of lifestyle modifications. And when they come back, if they remain hypertensive, they will start medicine. And remember, our first line for uncomplicated hypertension is a thiazide diuretic. So our risk factors for essential, we have SOSID-IC, for those of you that like mnemonics. So sodium and fat, obesity, oral contraceptives, and then even more of a risk factor would be oral contraceptives with smoking and obesity. But remember, smoking is not a risk factor. Stress, alcohol, African American, age, vitamin D deficiency, inactivity, and then caffeine and cholesterol. So your secondary risk factors, so things that we have a known cause, your aldosterone, if your aldosterone goes crazy, bad kidneys, catecholamines or Cushing's, your drugs, and endocrine. Remember, basically every endocrine disorder has high blood pressure. Smoking itself does not cause hypertension. However, if a hypertensive person smokes, their risk of dying from heart disease significantly increases. Please remember that. So considerations for the geriatric population. As you age, your blood pressure risk increases. The reasons for this: we have structural and functional changes in our heart. They include atherosclerosis because our arteries are hardening and stiffening, and they are not as elastic as they used to be. Another structural change is an increased stiffness of the walls of the heart. They don't buffer the pressure like they're supposed to. So we have an inability to store our energy that's needed to create our diastolic pressure, and this creates a widened pulse pressure. And remember, a widened pulse pressure increases our risk of increased intracranial pressure, it increases atherosclerosis, it increases aortic insufficiency. With the elderly population, remember, if the medicine is needed, you want to start low and go slow. So if they must get placed on a ACE inhibitor, we're going to give them like a 5 milligram lisinopril as opposed to a 20 milligram lisinopril that a younger person would get. And the older population is more susceptible to volume depletion. So we want to teach safety measures such as position changes slowly and supportive devices for walking. Always, 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 always. Health promotion and disease prevention. So you want a person to have a BMI of less than 30. If they're diabetic, that blood sugar needs to be regulated, so it needs to be maintained, preferably less than 150. Some diabetics let it get a little bit higher than that. We want to limit our caffeine and limit our alcohol. Notice I say limit. You do not have to stop drinking. You do not have to educate that they can never have another alcoholic drink again, but they need to drink in moderation. So no binge drinking. Stress management. Manage your stress. Do some meditation. Do some prayer. It's good for you. Stop smoking. Stop smoking. Do some cardio exercise 3 times a week and limit sodium and fat. These are things that we should be teaching our patients. Signs and symptoms. Well, there aren't that many because, hey, it's the silent killer, which means you don't know when your blood pressure's high. It is important to have accurate blood pressure measurement. The only way to always have accurate blood pressure measurement is to ensure your cuff is the proper size. So not too big, not too small. Target organs. Please know your target organs. They are your vasculature, your arteries, your heart, your kidneys, your brain, and your eyes. Tests. So when you start becoming hypertensive, you're going to start spilling protein into your urine. So you're going to do a urinalysis to see if there's any proteinuria. Do a metabolic profile to look at your BUN and your creatinine. Make sure that your liver enzymes are okay. Make sure your electrolytes are okay, especially if you're on a medicine such as a diuretic, which could lower your potassium or raise your potassium, or an ACE inhibitor or an ARB, which could raise your potassium. Look at your cholesterol counts, your EKG, and your echocardiography if left ventricular hypertrophy is suspected. Most importantly, for any patient that is on a blood pressure medicine, they need to be instructed to change positions slowly. They need to be careful when getting out of bed. Be careful when driving because a lot of these blood pressure medicines make you sleepy. And climb the stairs until the med effects are fully known, especially if they're geriatric. So I did not talk about these medicines in class because, hey, we talked about them 2 weeks ago. But I will give you some tidbits now because I'm recording. So diuretics, an example of a diuretic, we have hydrochlorothiazide, which is a thiazide diuretic, and furosemide, which is a loop diuretic. Then you have your potassium-sparing diuretics. One of those examples is spironolactone. So diuretics decrease our blood volume, help renal blood flow, and help improve cardiac output. So, and it rids the body of sodium. Our side effects would be postural hypotension, weakness, drowsiness, dry mouth, and thirst. So we want to monitor the potassium because our potassium could be high or low, right? What medicines make it low? The thiazides and the loops. And then what medicine makes it high? Your potassium sparing. It's in the name. So you want to teach the patient to eat potassium-rich foods for if they're on a loop diuretic or a thiazide diuretic, and then potassium-sparing food, like foods that are not high in potassium if they're on a potassium-sparing diuretic. And potassium-sparing diuretics can cause hyperkalemia and hyponatremia. Give them signs, like teach them what hypokalemia symptoms are and what hyperkalemia symptoms are. For your calcium channel blockers, we have your nifedipines, your diltiazem. Those are 2 examples. Calcium channel blockers reduce the cardiac afterload and workload. Your side effects, of course, are hypotension. It could cause bradycardia, dizziness, and edema. You do not want to discontinue suddenly because you can get some rebound, hypertension. You do not want to give with sick sinus syndrome or heart block. You're going to also want to use cautiously in a heart failure patient. Verapamil, one of the calcium channel blockers, can cause constipation, so you want to teach them to increase their fiber if they are on that. Also with calcium channel blockers, remember that it interacts with grapefruit juice. Anything that goes to the liver is going to interact with grapefruit juice. It will increase the medicinal effect of the calcium channel blocker. Beta blockers, anything that ends in LOL, so metoprolol, atenolol, nadol, they help cause vasodilation, decreasing cardiac output and heart rate by blocking the beta-adrenergic receptors of the sympathetic nervous system. So very important, they decrease the heart rate. So we need a heart rate before we give it. We need to make sure that heart rate is 60 or better and that blood pressure is 100 or better, because your side effects are hypotension, bradycardia, fatigue, weakness, heart failure. You want to teach somebody who is just starting a beta blocker that this can make you sleepy. It can knock you out. So they might want to try it at night to see how they're going to feel before they operate any heavy machinery. Also, with the sudden discontinuation of a beta blocker, they can get rebound hypertension. How about that? Angiotensin converting enzyme inhibitors. So these are your prils, lisinopril, captopril, and enalapril. They stop the conversion of angiotensin 1 to angiotensin 2, which reduces peripheral resistance. Your big adverse side effect, angioedema, adverse angioedema. It's rare, but it's life-threatening. So with this angioedema, their throat can swell up, their lip can swell up. They can have symptoms of an allergic reaction, like shortness of breath. People can also get a cough, which is the most common side effect. Most common side effect, that's a cough. However, you need to teach these people that if they develop a cough, they need to report that to their provider. So you want to teach your client to report cough, report signs of angioedema, and also to let them know that this medicine can cause their potassium to be high. So your ARBs, those are things that end in irbesartan, losartan. If they have angioedema on the prill, they're going to be put on an ARB. The ARBs block your angiotensin 2 effect, decreasing peripheral resistance. Again, your side effects are hypotension, of course, and hyperkalemia. It's contraindicated with pregnancy. You want to teach people to that it can cause heart failure and that it can cause angioedema, but it's less than an ACE inhibitor. So you want to educate on symptoms of heart failure and angioedema. The aldosterone receptor antagonists are not used much. Eplerenone is an example, but if you ever see this in a question, you need to know that this medicine is kind of like a potassium-sparing diuretic, so it can raise potassium. So don't combine a potassium-sparing diuretic with an aldosterone receptor agonist. The central alpha agonist, the big one is clonidine. They give the clonidine a lot for hypertensive urgency. It decreases peripheral resistance and blood pressure by preventing the reuptake of norepinephrine. You want to monitor the blood pressure and the pulse. It is not a first-line medicine, so if you see this medicine on a list somewhere, it's usually the third or fourth blood pressure medicine this patient has been put on. It can make you sleepy. They give this a lot to children to help them sleep at night. Other side effects of this medicine, orthostatic hypotension and impotence. Then we have our alpha adrenergic antagonists, which aren't used that much either. An example is prazosin. It vasodilates. You want to know if you ever see an alpha adrenergic, you want to monitor the blood pressure for 2 hours after the first dose. You want to teach them to use caution when driving until the effects are known and start low. Client education. So you want to teach your client to report manifestations of electrolyte disturbances. Most of the time it's potassium. So you want to teach them hyperkalemia, hypokalemia. Every once in a while, such as in a potassium-sparing diuretic, they might have hyponatremia. But potassium is your big electrolyte when it comes to these medicines. Stress the importance of complying. Many people think, oh, I'm good. I've been taking my medicine. My blood pressure's down. I don't feel any symptoms. Well, their blood pressure's down because they're taking the medicine. If they stop taking the medicine, their blood pressure is going to go right back up. So make sure they understand they need to take the medicine. What can happen if they don't take the medicine, i.e. stroke, heart attack, kidney disease? You want to make sure you give them verbal and written instructions on any medicine. Do the teach-back method. You want to ensure that they're capable of obtaining these medicines. Make sure they get regular checkups, especially when they first are diagnosed with high blood pressure. You want to emphasize lifestyle changes are needed. Even with medicine therapy, they need lifestyle changes. And remember that your older adults are always more susceptible to these orthostatic hypotension effects. Educate on the DASH diet. The DASH diet stands for Dietary Approaches to Stop Hypertension. It includes a large amount of fruits, vegetables, whole grains, lean proteins, salt limitation, and low-fat dairy. It's important to let them know that they should exercise 3 times a week, cardio exercise 3 times a week, and then they can advance it as needed. They should always seek the advice of a provider before they start exercising. And then smoking cessation and stress reduction. Those are very important. Hypertensive crisis. So we have urgency, we have emergency. Hypertensive emergency is defined as 180 over 120. Urgency is 180 over 110. That does not mean that you cannot have a higher blood pressure than 180 over 110 and still only have urgency. The big difference between the two is that with urgency, there is no impending target organ damage. You can have a headache, you can have a nosebleed, you can have anxiety, but you don't have anything else. You are not going to have weakness, you're not going to have numbness, you're not going to have tingling, you don't have those things. Those are target organ damage. Anything that you know is a risk factor for an MI, a stroke, that is target organ damage, and that happens in emergency only. So with urgency, which can be higher than 180 over 110, so don't think it can't be higher, your goal is to decrease your blood pressure to 160 over 110, and it can occur in an outpatient management type setting. With emergency, they will have target organ damage, and you want to reduce the blood pressure, but not quickly. The only exception with that is aortic dissection. If they have an aortic dissection, that blood pressure needs to get low and stay low until that aortic dissection is fixed. Hypertensive crisis, you want to recognize your manifestations, know that they are going to be on an IV medicine, titratable until they are stable. Their blood pressure needs to be monitored every 5 to 15 minutes until they're stable, and you want to assess their neuro and their heart rhythm every 3 to 4 hours. And that's pretty much it for hypertension. I hope you have enjoyed this video. Coronary artery disease to come sometime soon.